You're listening to Medscape's In Discussion series on respiratory syncytial virus in adults, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Forrest Arnold. Dr. Arnold is the chief of the University of Louisville Division of Infectious Diseases and director of the Center of Excellence for Research in Infectious Diseases. He also acts as the co-editor-in-chief for the Journal of Respiratory Infections and program director for the Clinical Fellowship in Infectious Diseases. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Forrest Arnold, and welcome to Medscape's In Discussion series on RSV in adults. Today we'll be discussing RSV in immunosuppressed patients who have had a bone marrow transplant or are receiving CAR T-cell therapy. Dr. Melody Smith is currently an assistant professor of medicine in the Division of Blood and Marrow Transplantation and Cellular Therapy at Stanford University School of Medicine. Welcome to In Discussion.
Hi, Dr. Arnold. Thank you for having me. I look forward to discussing infectious complications following bone marrow transplant and CAR T-cell therapy, specifically focusing on RSV. So thanks for having me here.
Oh, great to have you. Dr. Smith, we're familiar with RSV in pediatrics, but it is relevant in adults too. Every year, approximately 17 0 to 4-year-olds are hospitalized per 100,000 population. Adults are only about 3 per 100,000 population, but for adults greater than 85, the rate is more like 9, and this past year it peaked at 17, which is the baseline rate of those 0 to 4-year-olds. The elderly are vulnerable because their immune systems are down, and another vulnerable population is the group getting a bone marrow transplantation. Dr. Smith, please tell us, who is a typical patient that you see in your practice?
So in my practice, I focus on patients who have received bone marrow transplants, both allogeneic and autologous bone marrow transplants. So allogeneic being bone marrow transplants from donors and autologous transplant being bone marrows from the patient themselves. And I also take care of patients who receive CAR T-cell therapy. In my outpatient practice, though, my focus is on autologous and CAR T-cell therapy.
Very good. And how do you make the diagnosis of RSV?
So RSV can be made with a type of test called a PCR, where we can do a swab of the patient's nasopharynx or their nostril. And then from that, we can see if we're able to amplify the virus. And this is something that's really important to evaluate in our patients who have either type allogeneic or autologous bone marrow transplant or CAR T-cell therapy, because these are patients who have blood cancers and who are immune suppressed because of the treatment they've gotten for their blood cancers. But then in addition to that, after going through autologous or allogeneic bone marrow transplant, as well as CAR T-cell therapy, they're given additional types of chemotherapy as a part of this treatment that suppresses their immune system. So they're more at risk for upper respiratory viral infections, including RSV.
I see. And you're using nasopharyngeal swabs, correct?
Yes.
And we're all familiar with that from COVID-19. But I assume you're also using bronchoscopic samples as well.
Right. For patients who have more lung involvement, when we see findings on our chest x-rays that are concerning for RSV and patients are having more difficulty breathing, or we really want to just make an accurate diagnosis, bronchoscopy with washings of the bronchoscopy to be able to identify the virus is really important as well to the treatment process.
Yeah, and what morbidity do you see with RSV, and do you see mortality attributed to RSV in your patients?
I would say that mortality in our patients due to RSV is not as common in the adults that I treat as I would say some of my pediatric transplant or cell therapy colleagues. And so it's not something that I see often, that patients die because of complications of RSV. But if it goes untreated or if the treatment is delayed, those can definitely increase the potential that a patient may have complications leading to mortality.
Okay. And could you give us an example of somebody you see
with RSV?
Sure.
Yeah. So I would give an example of a patient who has received an allogeneic or donor bone marrow transplant, for example, a leukemia indication. They have received conditioning chemotherapy. got the bone marrow transplant. They're discharged because they've recovered from the bone marrow transplant. But on routine follow-up, we notice that they're having increased difficulty breathing, some stridor perhaps, and also may have decreased oxygen levels. And so we get a chest x-ray, which shows concern for RSV or a viral pneumonia. And so this is the type of patient that we would bring back into the hospital to evaluate them further. Oftentimes we do a nasal swab to evaluate for RSV, but we would also very promptly consult our pulmonary colleagues to plan for a bronchoscopy where we'd get those washings. And I would say that most often, if the patient is clinically stable, we would plan to not initiate treatment unless the respiratory swab was positive. We'd start ribavirin, but we would try to get the bronchoscopy as soon as possible related to the initiation of ribavirin so that that bronchoscopy yield can still be not diminished by the patient already starting on treatment.
And the immunocompromised state of these patients certainly justifies treatment. It's just that there's no FDA-approved treatment for RSV. Ribavirin, you mentioned, is FDA-approved for hepatitis C, which is not so relevant here. How do you administer the ribavirin?
Generally, it's not inhaled. It's an oral pill.
Intolerated.
And tolerated, yes.
And much easier to give than the hoods you have to get with the inhaled. Yeah, that's kind of a nightmare.
I think in the pediatric population, they seem to do a lot more of the TENS, from my understanding, the inhaled ribavirin.
I think you're right. Just the frequency of it makes everybody more comfortable with that administration. So for adults, there's 4 pharmaceutical companies working on an adult RSV vaccine, and one was just approved on May 3rd. Is there a role for the RSV vaccine in your pre-transplant preparations?
I think that's something that we would need to evaluate. We don't routinely give vaccines to prophylax against potential infections that patients may experience in the pre-transplant setting. Those vaccines are often given, not only the standard vaccines, but vaccines for infections that the patients may be more at risk for. They're generally given a year post-transplant. So I think that a study would need to be done to look at whether a pre-transplant vaccination would be beneficial, reducing morbidity, mortality in the transplant or cellular therapy population. But routinely, I would say the vaccines are most often given a year post-transplant once patients' immune systems have recovered such that they can mount a vaccine response. The reason I say that is if we were to give a vaccine in the pre-transplant setting, would we give conditioning chemotherapy or radiation to prepare the patient for the transplant? That would wipe out that immune response and they would need it again later. So the pre-transplant window would be not a long-lasting response in terms of immunity in the transplant population.
And do you already have a policy for your influenza vaccine that might be similar to what we'll see for RSV in the future?
Yes, well, we give those at a year post. We don't give them in that first year post-transplant.
Then not pre, or if they get it pre, it just happens to be with their usual standard of care?
Right, with their usual standard of care.
Okay, I got you. Well, so far, we've heard that RSV causes significant morbidity and even mortality in the bone marrow transplant population. There's no treatment available, but sometimes, rarely, ribavirin is used off-label. And prevention is important, and now with an adult RSV vaccine available, we'll have to figure out how to integrate it into this population.
Yes.
So if a patient is scheduled to get a transplant and it's just a couple days before they're going to get hospitalized and they get RSV, how does that interfere with the transplant schedule?
Yeah, that's a difficult position that we're sometimes placed in with RSV or other respiratory viruses. And what we do most often is we delay the transplant until the patient has clinical and symptomatic recovery, because we know that the patients coming in, say even just days before the transplant, if they're one of these viruses are positive, that in the setting of further immune compromised status, that a viral infection, which in a healthy individual could resolve, maybe even just be treated symptomatically, in our patient population, it could even increase the potential mortality of the transplant. So we would certainly delay until the patient has clinical recovery, most often clinical recovery. Sometimes these viruses the test can show positive for a while, even when the patient is clinically improved. So really the clinical symptoms are the thing we most monitor for.
Okay. And some unfortunate people get their transplant and then it's followed by RSV. And how does that affect their course?
Yeah, so that would be, we would work very closely with folks like you, our infectious disease colleagues, to do everything we could to treat, talk about giving the therapy that is available, such as ribavirin, including optimizing symptomatic treatment for the patients, hopefully avoiding the need that they would have decompensation that would require ICU care. But yeah, it would definitely require closer monitoring of the patients and working very closely with our infectious disease colleagues.
Okay. And then what if the transplant had been 6 months, a year and a half ago? How would that affect their course?
So I think with the plan for this new vaccine, if it's a year and a half post, that's where we could start thinking about therapy and then also incorporating potential vaccines for patients who are high risk. But the options for treatment would be still available, but not as concerning. The patient population is not as, let's say, delicate as an early time point post-transplant or the delay that would be incurred in the pre-transplant state.
Okay. And I know some of these late post-transplant patients go on to get graft versus host disease.
Yes,
and then,
that's a good point. I was just about to bring that up. Yes.
Well, if they go on to get RSV, then tell us about how that might affect their course.
Right. So one thing I was going to mention is, unfortunately, one of the potential complications after an allogeneic bone marrow transplant is the development of graft versus host disease, where T cells from the donor bone marrow can see aspects of the host or recipient's immune system as foreign and can attack various organs. And the most common organs that are involved are the skin, the liver, and the GI tract. And so these patients who develop graft versus host disease, either in the acute setting or chronic complications related to graft versus host disease, are on immunosuppressive medications. And so this would also be another population of patients where if they were to develop RSV, then I would recommend probably treating that patient as opposed to just symptomatically managing them, because again, they're immune suppressed. Compared to, and that's say a patient who is a year post and has GVHD, I would probably advocate for treating them even with ribavirin off-label, as compared to a patient who is 1 year post-transplant and doesn't have graft versus host disease. Their immune system is more robust. You could probably say maybe symptomatic management or still treat. So yes, definitely a patient with graft versus host disease is more immune compromised and has to be taken care of in that regard.
Okay. How does having or planning to receive CAR T-cell therapy affect the course of RSV?
So for our patients who are planning to receive CAR T-cell therapy, they get conditioning chemotherapy, which we touched on a little bit. And this conditioning chemotherapy is milder and not as prolonged as the therapy that's given prior to a allogeneic or autologous bone marrow transplant. The reason being is that the reason why we have to give these patients chemotherapy is just to deplete the number of T cells in their body so that when they get the CAR T cells can expand and proliferate and persist. And so what's really important to note is that we're starting to see, and various groups have published on this, that following CAR T-cell therapy, well, we know the patients are going to be lymphodepleted, so their T cells are going to be low. But we're also starting to see that patients are having more prolonged cytopenias. And those cytopenias are characterized by low neutrophil counts, which increases the risk for infections. Most commonly, we're seeing those are viral infections, including RSV. So to answer your question, essentially, for a patient who is post-CAR T-cell therapy, if they were to develop RSV, I would also, particularly in a patient who's lymphopenic or neutropenic, advocate that they should have treatment and not just be managed symptomatically, particularly if the patient has clinical symptoms that are concerning for RSV and not just a positive test.
Is there an area that you see RSV, just the knowledge of it, whether the treatment or I guess these vaccines are coming on, that you feel is really needed in the hospital with your patients?
I'm sure none of the initial studies have been done on immune-compromised patients because it makes sense that they would probably first evaluate a healthier cohort of patients when they're assessing for this vaccine, but it may be of interest to understand how the long-term memory of these vaccines in both healthy and potentially immunocompromised patients. And that would help benefit not only, I would say, transplanters, but oncologists and those who work with other immune-compromised patients to understand how they could incorporate this vaccine, how often would patients need to receive the vaccine, and how does the use of the vaccine impact hospitalizations, need for ICU care, and on other morbidity and mortality in patients who are immunocompromised and not in otherwise healthy patients.
The onset of this vaccine will answer some questions, but also generate a lot.
Yes.
Regarding the isolation precautions, the CDC says to place patients in the hospital in contact isolation, and I'm curious to know what they do at your institution.
So all of our patients, at least at my institution, who receive a transplant are in private rooms. So when they develop respiratory viruses, we put them on droplet precautions as well. And if the CDC recommends contact isolation, we would do that too. But generally for the upper respiratory infections, we do have patients on droplet precautions as well.
Okay. And it's important to call infection control because as closely as they follow the CDC recommendations, each hospital seems to be different.
Yeah. No, I think that your point about infection control, actually, if I may add, is really important. There are so many different upper respiratory viral infections that patients may have, and we keep them very closely involved in our patients. So whatever virus they may have, as we know, sometimes these guidelines change. Not only can they be different from one institution to the other, but there may be new recommendations that come forth and the guidelines change. So we generally just reach out to them when one of our patients has a respiratory virus, RSV or otherwise, so that we can make sure that we're following the most up-to-date guidelines in terms of their management.
Right. And I think people do follow the contact isolation, and probably a lot like your place and mine, we add droplet isolation on top of it.
Yeah.
The other variable is how long do you keep them in isolation? And that is not included so well.
Yeah.
And again, it's another call to infection control. How long do they want them in?
I go with what they say because generally they have very clear guidelines in terms of that. And the other thing that's really important about keeping the patients in isolation for an adequate amount of time and for that requisite amount of time that's recommended is that we want to make sure that the patients recover and they're safe and healthy, but that all the patients around them, if they were to be walking in the hall, et cetera, don't contract RSV or a virus like that could be really complicating to other patients' care. So for that reason, I really do defer to our infection control and their guidance.
Very good. Today, we've had Dr. Smith discussing RSV in patients who have had either a bone marrow transplant or CAR T-cell therapy. RSV may postpone therapy or prolong the course if they've already had a bone marrow transplant. If treatment with ribavirin is used, it is off-label. And finally, isolation is contact isolation plus whatever your specific hospital requires. Thank you so much for joining us. This is Dr. Forrest Arnold for In Discussion.
Thanks for listening to Medscape's In Discussion Respiratory Syncytial Virus in Adults podcast series with our host, Dr. Forrest Arnold. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on respiratory syncytial virus in adults.